Hello, everyone. Good afternoon. My name is Cecilia Kisi. I'm a pharmacist with Sevier. I'm your moderator this afternoon for this online CPD program. And we are going to discuss on managing hypertension in patients with comorbidities. And to help us facilitate this program this afternoon, we have two speakers. Our first speaker is an interventional cardiologist and a lecturer at Kolebu Teaching Hospital. Also at the School of Medicine and Dentistry, College of Health Science, University of Ghana, Legon, and is in the person of Dr. Francis Echekum. Our second facilitator is Dr. Frederick Asumeni-Akoto. He's also an internist and a cardiologist at the University of Ghana Medical Center. So there are going to be three parts of the presentation. Dr. Echekum will present on hypertension and comorbidities. And then Dr. Akoto will give us two clinical cases that practically he handled. And then I'll come in with a short discussion from Sevier. Then we'll take the questions and the Q&A section, and then we'll be done. I think in the next 1 hour, we should be done. So now I want to invite Dr. Francis Echekum to take us through hypertension and comorbidities. Please, let's welcome Dr. Francis Echekum.
Hello.
Hi, Dr. Echekum.
Yes, Cecilia, good afternoon. I hope you're doing well.
Yes, please, I'm doing well.
Thank you. And good afternoon to you all. Thanks so much for joining. This afternoon is going to be a short interaction, and I believe we are all going to enjoy the interaction this afternoon. Okay, so can I have my slides on? Good. All right. So as Cecilia has already mentioned, we are going to be looking at managing hypertension in patients with comorbidities. We know hypertension is a very common condition. In fact, it is one of the more common killers world over. So it doesn't also come alone. It comes with other conditions. So this afternoon, we will be looking at this. This presentation, the scientific steering committee that made this presentation as shown above, and I will be the one presenting for this afternoon. There are 5 key questions we're going to be asking ourselves this afternoon or try to answer. And the main thing is whether these questions are facts or they are just fake news that are being bandied around. And these are the main objectives, to be able to decipher the facts from the fake. And that will help us in managing our hypertensive patients very well. So the first one is up to 66% of patients with hypertension have other comorbidities. Is it true? Is it false? Or I don't know. I'll give you 10 seconds to think through it. Up to 66% of patients with hypertension have other comorbidities. True? False? I don't know. Indeed, if you look at the 2019 causes of death, global causes of death, hypertension is the number 1 risk factor for death. If you rank the top 10 causes of death, hypertension is the number 1. But that is not the only cause of death. There are other risk factors like tobacco smoking, nutritional risks, air pollution, high BMI, and others. And indeed, if you look at those that are shaded in red, it indicates the metabolic risk factors that tend to coexist. And hypertension usually does not exist as a single disease. It comes with other comorbidities. You will see hypertension coexisting with other metabolic diseases like diabetes, dyslipidemia, obesity, and other things. This slide is very interesting and important. 2 in every 3 patients with hypertension have other comorbidities. And if you take people with comorbidities, 2 in every 3 patients with comorbidities have hypertension as one of the comorbidities. Indeed, if you take hypertensive patients, 49% of them have dyslipidemia, up to 29% of them have type 2 diabetes, and up to 70% of them are either overweight or obese. And the same story can be said about people who have dyslipidemia. Of the people with dyslipidemia, up to 64% of them have hypertension, and about 50% of them are overweight or obese. Similarly, if you take people with diabetes, about 75% of them have hypertension, and almost 90% of these patients are overweight or obese. Another up to 60% of them have dyslipidemia. So indeed, it is a fact that hypertension does not exist usually as a single entity, but coexists with others. Look at the INTERHEART study. This was a study that looked at the causes or risk factors for myocardial infarction in the community. And if you take at the risk factors, about 9 risk factors accounted for almost 90% of the myocardial infarction that presented. And of these, if you take a look at the risk factors, the more risk factors one has, the higher the odds of developing myocardial infarction. If you have only hypertension, the odds of developing myocardial infarction is about 2 times. However, if you had hypertension, smoking, diabetes, and dyslipidemia together, this odds increase more than 20-fold. What that means is that if you have a patient with hypertension, that patient is also likely to have other comorbidities. And if you ignore these comorbidities, it is going to lead to detrimental effects. So you need to be able to manage these patients totally, looking at their hypertensive status as well as other comorbidities that may coexist. So our first fast check is true. Up to 66% of patients with hypertension have other comorbidities. And that is important fact for us to know. This is not a fake news. The second one, ACE inhibitors are recommended as first-line treatment, and ARBs if ACE inhibitors are not tolerated in guidelines for some hypertension comorbidities. Is this true? Is this false? Or I don't know. I give you another 10 seconds to think through it. ACE inhibitors are recommended as first-line treatment, and ARBs if ACE inhibitors are not tolerated in guidelines for some hypertension comorbidities. True, false, I don't know. Now let's look at the facts. If you take a look at the recent hypertension guidelines, their views on the use of various medications and their interpretation of evidence is a little bit different, but there is a core theme that appears. If you take a look at the 2018 European Society of Cardiology and the European Society of Hypertension guidelines, the main focus is, and what they stated was the most important benefit of antihypertensive treatment is due to reduction in blood pressure. So the focus is on reducing blood pressure, whatever means you reduce the blood pressure. And once blood pressure is reduced, it leads to benefits, and that is a fact. For the tendency was to merge the RAAS blockers into one, like ACE inhibitors, ARBs, no attempt to differentiate them, make them into one, because if you take a look at the hypertension reducing effect of these medications, they tend to be similar, and therefore they tend to use these terms interchangeably, ACE inhibitors or ARBs. We will look at these guidelines a little bit into more detail. However, if you take a look at the 2020 International Society of Hypertension guidelines, they were more emphatic. They look at randomized controlled trials. And when you look at the randomized controlled trial-based benefits, there is some difference between ACE inhibitors and ARBs, and they were not always identical. So they said that choice between the two drugs of RAAS blockers would depend on patient characteristics, availability, cost, and tolerability. So these drugs are not the same when it comes to certain hypertensive patients with certain comorbidities. Hypertension, non-complicated hypertension, yes, they all reduce the blood pressure. But if you have patients who have other comorbidities, then there seem to be some differences in these medications. Then take a look at the Canadian hypertension guidelines, also in 2020, and they stated that ACE inhibitors are preferred in specific types of patients. ARBs if ACE inhibitors are not tolerated. And these conditions they listed were coronary artery disease, recent myocardial infarction, heart failure, post-stroke or TIA, and chronic kidney disease. So if you have a patient with hypertension who has any of these comorbidities, then ACE inhibitors are preferred. If they cannot tolerate ACE inhibitors, you go for ARB. Now let's take a closer look at the management of hypertension, which is not complicated, uncomplicated hypertension. And this is from the European Society of Hypertension guidelines in 2018. The emphasis here is on early control of blood pressure. As you are able to control your blood pressure early, it leads to benefits. So the emphasis is on initial dual therapy for most patients, and that must be in a single pill combination drug. This is for most patients. For a few patients who are elderly, who are frail, whose blood pressures are not so high, who do not have any comorbidities, or who do not have any target organ damage, you may choose to start with one medication. But for majority of your patients, it is recommended that you do dual antihypertensive therapy in a single pill combination. If the blood pressure is not controlled in about a month, you need to move on to a triple combination therapy. And that is also recommended that you do a single pill triple combination therapy. So if you have a drug that contains all the three agents, it is preferred. And this should be a combination of ACE or ARB, CCB, or a diuretic. If after 3 months of triple combination therapy, these patients are still not controlled, then you are dealing with resistant hypertension. So in that case, you are going for a 2-pill therapy where you are adding other agents to your triple single pill combination therapy. So the preferred one will be spironolactone, but you can also add other agents like your other diuretics, beta blockers, and things like that. However, if there are compelling indications for the use of beta blockers, then at any stage in the hypertension treatment, you can use beta blockers. So, for instance, if a patient presented with hypertension and had myocardial infarction as a comorbidity, you are not going to be using calcium channel blockers at this stage. You need to add a beta blocker in your initial combination therapy. So there is room for specific adjustments depending on the patient characteristics. So the important thing is look at your patient. What are the features? What characteristics? What other comorbidities does the patient have to be able to manage the hypertension very well? This is the European guideline, but there is continuous evidence-based support of ACE inhibitors in guidelines of main hypertension comorbidities. And if you take a look at the cardiovascular continuum, at every stage, there has been other guidelines that have been developed. And when you take a specific look at these guidelines, you see that there is a focus more on ACE inhibitors rather than the ARB. So if you take a look at the 2019 ESC guidelines for diabetes, pre-diabetes, and cardiovascular disease, this was developed in 2019. They recommended ACE inhibitors and ARBs if ACE inhibitors are not tolerated. And this story runs through all the other guidelines. 2019 ESC guidelines for diagnosis and management of chronic coronary syndromes, ACE inhibitors are preferred. If patients are not tolerant of ACE inhibitors, go for ARBs. If you take a look at the 2020 ESC guidelines for the management of acute coronary syndromes with non-ST elevation myocardial infarction, they also say that ACE inhibitors, if they are not tolerated, go for ARBs. If you take a look at the latest heart failure guidelines, 2021 ESC guidelines on heart failure with reduced ejection fraction, ACE inhibitors are preferred, or ANIs, if not tolerated, go for ARBs. So all the guidelines look at ACE inhibitors as the preferred agent. So this statement, ACE inhibitors are recommended as first-line treatment, and ARBs, if ACE inhibitors are not tolerated in guidelines for some hypertension comorbidities, cannot be anything but true. Now let's take a look at the third fact check. ACE inhibitors and ARBs are equivalent at reducing all-cause mortality and CV mortality in high-risk patients. Is this true? Is it false? Or I don't know. I'll give you some 10 seconds to think through. ACE inhibitors and ARBs are equivalent at reducing all-cause and cardiovascular mortality in high-risk patients. This was a meta-analysis that was done of 20 trials, ACE inhibitor and ARB trials, involving close to 160,000 patients. And if you take a look at all the studies that were looked at, those which were with ACE inhibitors had a hazard ratio of greater than 1, showing significant benefit. And the primary endpoint was cardiovascular MACE. And if you take a look at studies that use ACE inhibitors, there was benefit. Whereas when you take a look at those that were using ARBs, of the studies that were included, there was not much benefit. In fact, the only one that showed some benefit was the LIFE trial that used a combination of losartan and hydrochlorothiazide. So many of the studies that have been done with RAAS inhibitors or RAAS blockers are with ACE inhibitors that are showing significant benefit. This is also another meta-analysis that is looking at various cardiovascular endpoints. And the cardiovascular endpoints are the all-cause mortality, cardiovascular mortality, myocardial infarction, and stroke. And here they were looking at the number needed to treat. How many patients do you need to treat to receive benefit? And comparing ACE inhibitors and ARBs. If you take a look at all-cause mortality, number needed to treat for ACE inhibitors was 67 compared to 335 for ARBs. Take a look at cardiovascular mortality. Number needed to treat for ACE inhibitors, 116 compared to over 400 for ARBs. And this runs through all of them. So you cannot say that ACE inhibitors and ARBs are the same medications, or when it comes to cardiovascular mortality and cardiovascular outcomes. This is also another meta-analysis that is looking at the various benefits of ACE inhibitors versus placebo, ARBs versus placebo, ACE inhibitors versus other antihypertensive medications, ARBs versus other antihypertensive medications. And if you take a look at them, many of the evidence we have as far as ACE inhibitors are, as far as RAS blockers are concerned, are with ACE inhibitors rather than with ARBs. The white areas show that there is no sufficient evidence as far as that particular outcome is concerned, and look at the ARBs. There are no sufficient evidence. When it comes to cardiovascular coronary heart disease, actually the red is worse outcome. And this is what was sometimes ago termed as the ARB myocardial infarction paradox, where people who received ARBs actually had worse outcomes when it came to myocardial infarction than those who received other antihypertensive medications. So these two medications cannot be said to be of the same efficacy as far as cardiovascular outcomes are concerned. And of course, their mechanism of actions are also not the same. So we cannot put them together as a single medication. Therefore, it is a fact that ACE inhibitors and ARBs are not equivalent when it comes to cardiovascular disease outcomes and all-cause mortality. Fact check number 4. In patients with diabetes or prediabetes, ARBs are more effective than ACE inhibitors. Is it true? Is it false? Or I don't know. In patients with diabetes or prediabetes, ARBs are more effective than ACE inhibitors. True? False? I don't know. Now let's take a look at some important facts. In hypertensive patients with prediabetes or diabetes, which RAAS blockers should we choose? And this question was answered in the 2019 ESC guidelines on diabetes, prediabetes, and cardiovascular disease that was developed. And if you look at it, BP control often requires multiple drug therapy with a RAAS blocker and a CCB or a diuretic. And usually you need more than one medication to be able to control your blood pressure. But what they said is that dual therapy is recommended as first-line treatment. Evidence strongly supports the inclusion of an ACE inhibitor or an ARB in patients who are intolerant of an ACE inhibitor. And this is another meta-analysis that is looking at the evidence for the use of ACE inhibitors and ARBs in patients who have prediabetes or diabetes. For all the ACE inhibitor-based regimens, you realize that it provides significant benefit as far as reduction in renal outcomes, 21% reduction in renal outcomes, 18% reduction in cardiovascular mortality, 14% reduction in all-cause mortality. Whereas when you take a look at the ARB studies, including the IDNT, the RENAL, the DIRECT, the roadmap studies, there was a significant reduction in renal outcomes, 20% reduction in some of them. And then, whereas if you take a look at the cardiovascular mortality and the all-cause mortality, there was no benefit. So you cannot say by this meta-analysis that ARBs are more effective in patients with prediabetes or diabetes than ACE inhibitors. Indeed, the reverse can be said to be the case. Therefore, in patients with diabetes or prediabetes, the reverse, ACE inhibitors are more effective when it comes to cardiovascular disease outcomes, cardiovascular mortality, all-cause mortality. They are equipotent in reducing renal disease outcomes. Then we take a look at hypertensive patients with CKD. And this was also the guideline that was released by the American College of Cardiology, the American Heart Association guideline. In adults with hypertension and CKD, treatment with an ACE inhibitor is reasonable to slow kidney disease progression. Treatment with an ARB may be reasonable if an ACE inhibitor is not tolerated. So this is also from the same guidelines. And if you look at the evidence that was used in developing these guidelines, if you take a look at all the ACE inhibitor studies, and they included a number of ACE inhibitor studies, advanced, the Benedict, all these ACE inhibitor studies, ACE inhibitors showed significant outcome versus placebo for new onset kidney disease and all-cause mortality. Whereas if you take a look at the ARB studies that were included, the DIRED, all the other studies that have been mentioned already, ARBs showed no significant outcomes versus placebo. And this one, they were looking at all-cause mortality. So ACE inhibitors tend to show more benefit when it comes to hypertensive patients with CKD, according to this meta-analysis that was conducted. Then take a look at another meta-analysis. This was a systematic review and Bayesian network meta-analysis of 119 randomized controlled trials that involved up to 64,000 patients. And if you take a look at the outcomes, the risk of kidney failure versus placebo, risk of kidney failure versus active control, both ACE inhibitors and ARBs showed significant reduction. Whereas when you take a look at the risk of CV death and all-cause death, it was only ACE inhibitors that showed significant reduction, and ARBs did not show that significant reduction. So these two medications, as I keep saying, are not the same. Another fact check we want to do is ACE inhibitors and ARBs are equivalent at reducing all-cause and CV mortality in patients with coronary heart disease. That's also another important comorbidity for hypertension. Hypertensive patients with coronary artery disease, are these medications equivalent? This was also addressed in the 2019 ESC guidelines for diagnosis and management of chronic coronary syndromes. And if you take a look at it, the statement is ACE inhibitors can reduce mortality, MI, stroke, and heart failure among patients with left ventricular dysfunction, previous vascular disease, and high-risk diabetes. It is recommended that ACE inhibitors or ARBs in cases of intolerance be considered for the treatment of patients with chronic coronary syndrome with coexisting hypertension, left ventricular ejection fraction 40% or less, diabetes or CKD, unless there is a contraindication. And this was backed by a lot of evidence. You have several studies that back this statement. That was MASOLVE trial, the SAVE trial, the L, and so many other studies all show that in CAD patients, ACE inhibitors show significant benefit in terms of reducing all-cause mortality and cardiovascular mortality. So the two are not equivalent when it comes to reducing these cardiovascular disease outcomes. Another important group of patients with hypertension, hypertensive patients with heart failure, are ACE inhibitors and ARBs equivalent? And the guideline, the 2021 guidelines I made reference to earlier on, said that an ACE inhibitor is recommended for patients with heart failure with reduced ejection fraction to reduce the risk of heart failure hospitalization and death. An ARB is recommended to reduce the risk of heart failure hospitalization and CV death in symptomatic patients unable to tolerate an ACE inhibitor or ANI. And these patients should also be on other medications as recommended. So clearly, when you look at the latest guideline for heart failure, they separated these two statements. Initially, they were together like ACE inhibitor, if not tolerated, ARB. But in this particular guideline, they actually separated the two sentences. They have the ACE inhibitor and ANI as a first statement guideline. And then if patients are not able to tolerate these medications, then they recommend the use of an ARB. So these medications are not the same. And there's also a lot of evidence to back these ones. When you combine these medications with other medications, your heart failure outcomes are much, much better than when you put them on single therapy. So it is important that when you have a hypertensive with heart failure with reduced ejection fraction, the combined therapy, now we talk about 4 foundational drugs, and these foundational drugs must be included in your patient's therapy to improve their outcomes, hospitalizations, mortality, and others. This is getting close to the end of my presentation. So there's also other evidence to show that so many medications, when they are combined together, they help with your heart failure patients. ACE inhibitors, we have looked at several studies that have shown that beta blockers also have a lot of studies to back their use in heart failure with reduced ejection fraction. Mineralocorticoid receptor antagonists like spironolactone, eplerenone, they also have a lot of studies to back their use in heart failure with reduced ejection fraction. ARNIs, angiotensin receptor neprilysin inhibitor, they also have a lot of studies to back their use in heart failure. And now the latest kit, the SGLT2 inhibitors, also have a lot of studies now. We are looking at more than 4 studies now, large randomized controlled trials to back their use in heart failure with reduced ejection fraction. So for patients who have hypertension with heart failure comorbidity, there are medications that need to be used together to achieve important benefit as far as cardiovascular disease outcomes are concerned. So in summary, ACE inhibitors, but not ARBs, have been shown to significantly reduce all-cause mortality, CV mortality, and morbidity in high-risk patients with hypertension. You should consider the patient and all comorbidities when you are choosing your specific medications and guidelines that you are using to manage this patient. The important thing is that you must remember to treat the patient and not the disease. It's not every disease that is the same. The patient, what other comorbidities does the patient have? A patient with hypertension without any comorbidities is not the same as a patient with hypertension with heart failure, or a patient with hypertension with coronary artery disease, or a patient with hypertension and diabetes. So treat the patient and not the disease. In the end, ACE inhibitors may be considered as first-line therapy in many patients with comorbidities, and ARBs if the patient is not able to tolerate ACE inhibitors. Thank you.
Thank you so much, Dr. Jekum. Please, if we have any questions, we could put it in the chat box, and then at the end of the presentations, we are going to answer all those questions. So we'll move ahead to the second presentation by Dr. Akoto. He's going to share with us 2 practical cases that he's dealt with. So without much ado, I leave the floor to Dr. Akoto.
Hi, hello, good evening. So we would, as Dr. Ejekum has led the evidence, which is clear, we would now look at 2 cases with different scenarios and comorbidities and see how we navigate these patients. So our first one is a 55-year-old male who has a 10-year history of hypertension. Indeed, he has had numerous combination therapies, including monotherapies as well. Initially started on the calcium channel blocker. It was stopped because he had complaints of ankle edema. And then subsequently had been seen and treated with ramipril, nebivolol, but of course, he didn't achieve good control. Eventually, we changed to ramipril, hydrochlorothiazide, and nebivolol. But then whilst at home, when we asked him to monitor his blood pressure, he came back with home BPs which were hovering in the 150s and diastolic in the 90s. So indeed, his blood pressure control was not adequate. But hearing a family history of his father having passed on at 54 years due to an MI, but then lost his mother to breast cancer, both of them were hypertensive, but then there was no history of diabetes in the family. So a significant point here is having had a father who had died at 54 years with myocardial infarction. He concedes that he eats a lot. He doesn't play with his food and moderately indulges in alcohol. Because of his work schedule, traveling up and down, he takes a lot of coffee. He previously smoked, but at the time he was doing about 20 cigarettes per day. I should say this an expert, so we should know where we are coming from. And he barely exercises, traveling from Lebanon back to Ghana to the US, up and down. So no physical activity at all. When we examined him, he's obviously was obese. His BMI was 32. Office BPs were still in the 150s or 90s. His heart rate at the time was 60 beats per minute. Cardiovascular examination, as you say, was normal. His chest findings were unremarkable. The first time he was seen, this was his ECG. This was not when we saw him, but this was his ECG prior to we seeing him. So indeed, there was no evidence of chamber hypertrophy. But then when we did the ECG, having seen him, there was evidence of suspected left ventricular hypertrophy. We can see that the voltage criteria, S in V1 and R in V5, amounted to more than 35 millimeters. This was a suspicion. We went on and did an echocardiogram, and lo and behold, he had concentric left ventricular hypertrophy. His left ventricular mass index was way above 50, which is the cutoff point that we used. And then also found out that because of the left ventricular hypertrophy, the left ventricular filling pressure was elevated, which we see by this mitral inflow Doppler representation. He did have an echo Doppler of his carotid arteries, which showed that he did have plaque, even though it was not significantly stenosed. His laboratory test came back showing that his fasting blood sugar was impaired, 6.6. His creatinine was 102 micromoles, but his EGFR put him at stage 2. Uric acid, the BUE, and creatinine, the sodium, potassium were all essentially normal. He was lucky. His lipid profile were within limits. By hearing an albumin creatinine ratio showed that he had moderately increased albuminuria. So this is a man who has poor hypertension control. He has target organ damage characterized by left ventricular hypertrophy. He had carotid atherosclerosis. He has a first degree relative who passed on with myocardial infarction, which is an independent risk factor for cardiovascular disease. And his obesity doesn't portend well for him at all. And coupled with a chronic kidney disease, which we know also speeds up cardiovascular disease. Indeed, most of the death in chronic kidney disease is as a result of cardiovascular disease. And then his impaired fasting glucose. So how do we attempt to modify his risk factors or treat him? I should say his uncontrolled hypertension, his pre-diabetes, his chronic kidney disease, as well as obesity and a sedentary lifestyle. And as the evidence has been shown, Dr. Ejekuma just mentioned it, that in patients with hypertension and pre-diabetes, the ACE inhibitors have been shown, on top of their benefit with the renal outcomes, cardiovascular and total morbidity is much improved with the use of ARBs. And indeed, in the presence of CKD, the ACE are known to slow down the progression of the proteinuria, which indeed also speeds up the reduction in renal function. So in his case, the ACE inhibitor is highly indicated in view of one, his uncontrolled hypertension, two, his renal impairment, and then in the presence of the diabetes, which can also speed up the progression of the renal dysfunction, the ACE inhibitors have been shown to reduce the outcomes in terms of new onset kidney disease and also all-cause mortality attributable to CKD, as well as the fact that the ACE inhibitors, their impact on CV death and all-cause mortality can only be seen with the ACE inhibitors and not the ARBs. So in this patient who has hypertension, who has CKD, who has pre-diabetes, the ACE inhibitors are clearly indicated. Our second case was one of a 60-year-old male who currently smokes. He neither indulges in any physical activity at all. His BMI also put him in the obese range, but then he came in with shortness of breath. 6 years ago, he had an MI, which resulted in acute heart failure. And at the time, he was fortunate to be able to afford a primary PCI, at which time he had never been told his cholesterol was high, he had never been told he was hypertensive, but subsequently was treated for these two risk factors. So his medications that he was taking included aspirin and clopidogrel. He was on a statin and then ezetimibe as a means to try and tighten the control of his cholesterol, beta blocker and perindopril. When we examined him, his blood pressures were not controlled. So he was 140 on 80, his heart rate seemed to be controlled, and his BMI, as usual, had not changed. But he did have peripheral edema. His labs, HbA1c was normal. He had stage 2 CKD as well. Chest X-ray was cardiomegaly. He had pulmonary congestion, cephalization of the pulmonary arteries. Echo showed that his ejection fraction was normal. He didn't have LVH, but then his pulmonary artery systolic pressure was elevated. Normally, it should be less than 20 millimeters of mercury. Sorry about it's 45. So this tells us that he does have an increased intracardiac pressure. So he does have diastolic dysfunction, and therefore his pulmonary pressures are elevated, coupled with the fact that the end-terminal pro-BNP showed an elevation, which is in keeping with the increase in intracardiac pressures. His LDL cholesterol was normal. But of course, he concedes that he snores. When he wakes up, his sleep is unrefreshing and usually goes to work with headaches. And whilst at work, at any chance, he will fall asleep. So this sounds like somebody who's having obstructive sleep apnea and poor sleep, insomnia, and daytime sleepiness. He has a good insurance. So because of the fact that he did have dyspnea on exertion, which is an angina equivalent, having had the previous MI, could it be that he had a restenosis in that same vessel or in a different coronary artery territory? So he had a coronary angiogram and there was no significant lesion seen. He did have a renal artery Doppler ultrasound, which did not show any stenosis, because having had atherosclerosis on other cardiovascular beds, then it was okay to also look at the renal arteries as well. He did have a sleep study. Of course, the number of times that he completely ceased breath and even had a reduction in his breath was almost 40 episodes per hour. Normally, it should be less than 5. So this tells us that he has a very big problem in terms of his sleep. When he sleeps, his airway is totally blocked. So this our patient, one, has uncontrolled hypertension. He has coronary artery disease, and previously he's had an acute coronary syndrome, which has been stented. And then he now comes in with heart failure with projected ejection fraction, chest congestion. And then because of the fact that he's overweight, he doesn't exercise, he smokes, and he has sleep apnea. So this is a patient who has hypertension and other comorbidities. So it's not simply just a hypertensive patient, as Dr. Joshua mentioned. Treat the patient. So, in trying to solve his acute congestion, diuretic, we added on an SGLT2, and he needed an MRA as well. But then his ACE inhibitor, which will give him much benefit, which he was already on perindopril, having gone out of the acute heart failure, it was decided to add on indapamide so that he get a dual combination of perindopril and indapamide. For his coronary artery disease, well, at the time he wasn't having any symptoms, so we maintain him on his beta blocker, his perindopril, he continued his statin and his antiplatelet. But of course, he had to be referred to see a respiratory physician who recommended that he need CPAP, and then he was advised to stop smoking. So the evidence has been adduced already, is incontrovertible, that this was a patient who has myocardial infarction, he has heart failure, he has pre-diabetes. In all this, the ACE inhibitors stand tall. The ACE inhibitors stand tall. So the evidence is clear. So that's why we persisted with his perindopril, optimizing it. And as been already stated, having left ventricular dysfunction as a result of a coronary artery disease, the ACE inhibitors are your best bet. And also in the face of diabetes, which also increases his risk. So I will end here with regard to the two cases as we've discussed, and we would let the moderator come in, and if there are any questions, we'll try and address them. Thank you very much.
Thank you so much, Dr. Akoto. So I'll wrap up the presentations with a short one from Xavier, and then we can take the Q&A. So please, you can start sending your questions to the general question box, and then after my short presentation, we'll deal with that. So I will talk about the perindopril adenine family at the heart of the cardiovascular continuum. Throughout the presentations, it has come out strongly that the ACE inhibitors are better than ARBs when it comes to cardioprotection and the other protections from the other cardiovascular continuum. And in Xavier, we give you the best ACE inhibitor called perindopril arginine, and it is branded in our market as Corvesol. I'm sure most of us are familiar with Corvesol. And so I'll go straight to the point. Dr. Joku mentioned the cardiovascular continuum. Here we say perindopril is at the heart of the cardiovascular continuum because of the various moving mortality studies that has been done. So as you can see here, these are summary of moving mortality studies of ACE inhibitors and ARBs. And the violet ones represent positive studies that met the endpoint. The down one are negative studies. And so as of now, you realize that among the RAAS blockers, perindopril stands tall, boasting of 6 moving mortality studies all across the cardiovascular continuum. So we have the ASCOR that talks about your hypertensive with 3 risk factors for coronary heart disease. Advanced is for your hypertensive diabetics. High risk is for your hypertensive who are elderly, and perindopril preventing a primary stroke. We have Europa, which talks about perindopril preventing a secondary coronary artery disease event. Progress is for your post-stroke patient, perindopril's ability to prevent a secondary event. PREMI talks about perindopril's ability to reverse LVH, and then we have PEP-CHF. So we are admonishing that as clinicians, in order not for your patients to further go through these complications, they can start their hypertension journey on Corvesol based combinations, so that they don't progress faster on this cardiovascular continuum. But if you meet them at a point where they've already developed complications, all hope is not lost. As you can see, we have done studies to show that Corvesol can prevent secondary events. So of course, as Dr. Ejokuma shared, you realize that the unique property of Corvesol giving you all this cardiovascular protection just goes beyond blood pressure reduction. It's because of its unique pharmacological properties and its unique activity beyond blood pressure reduction. So it's the most lipophilic among the ACE inhibitors. We know that for the ACE enzyme, there's 5% in the blood and 95% in the tissue. So if you are more lipophilic, you can cross the phospholipid layer and inhibit the tissue ACE, therefore causing a strong BP reduction and then extravascular effect. It's been also shown to give you a full 24-hour coverage. And as this has been shown by the trough to peak ratios. The trough to peak ratio represents the efficacy of the drug in a 24-hour period. I'm sure most of us have done emergency covers, and we usually may see stroke patients coming in at the early mornings between 4 to 8 a.m. Most likely because for the hemorrhagic, the circadian rhythm BP rises in the morning, and of course the molecules tend to also wear out of the system, and it's because of the trough to peak ratio. But Coverso stands tall with regards to giving you a full 24-hour blood pressure control because of the high trough to peak ratio. So we are not saying your patient should miss their dose, but if they do, there's still some sort of coverage for them, and this adds on to the reason why Coverso is more cardioprotective for your patients. In addition to the fact that it's been shown to reduce arterial stiffness, prevent early atheroma plaque, as was seen in the Europa study, and prevents cardiac remodeling, controlling central aortic blood pressure, correcting left ventricular hypertrophy, and generally restoring your endothelial dysfunction. And so for your hypertensive with comorbidities who need monotherapy, we have the plain ACE inhibitor, perindoprol, as Coverso, 5 and 10 milligram. Within 3 months, you can get as high as 22 millimeter drop in systolic blood pressure for your patients. Also, for your hypertensives experiencing microalbuminuria, they could do just one tablet of Coverso, 10 milligram, and within 1 month, you would have that regression in the microalbuminuria. For those who are uncontrolled on monotherapy, oftentimes amlodipine, or you're newly diagnosed who need the dual therapy right from the start, we've combined the perindoprol and amlodipine as Coveram in 4 single flexible dosages. So the first one being the perindoprol, the second being amlodipine. We have the 5-5, the 5-10, the 10-5, and 10-10. And with just one tablet of Coveram, you can guarantee your patients as high as 42 millimeter drop in mercury in just 3 months of therapy. In addition to this, you have a powerful cardiovascular protection, as was seen in the ASCOT study. The main endpoint, primary endpoint, which lasted for 5 years, was cardiovascular mortality, kidney failure, and total mortality. And these are the percentages by which perindoprol reduced it. But I mean, we also wanted to follow them up to see the legacy that Coveram leaves for them. And so we followed these patients up 16 years, and then there was a benefit in reducing cardiovascular mortality by 21%. Last year, ASCOT was 20 years. So we did another trial to compare for those who took Coveram in the 5 years long life trial. 20 years down the line, whether they were on Coveram or not, the benefits that Coveram has given them. And you realize that there's actually a reduction in the percentage of stroke and cardiovascular events. And so this comes a long way to confirm that your perindoprol-based combination gives you that short and the long-term cardio protection that your patients require. One of the main side effects of amlodipine is pedal edema and erectile dysfunction. And it's because, as seen on the left diagram, it dilates the precapillary arterioles and not the postcapillary venules. So it allows the blood, it constricts and creates that intracapillary pressure, so allowing the fluid to seep into the surrounding tissue, causing pedal edema. But when it comes to perindoprol, perindoprol has effects on the postcapillary venules. So it opens it up and then allows the blood to freely flow. So even though Coveram contains amlodipine, the incidence of pedal edema is greatly reduced with Coveram. And of course, for erectile dysfunction, it's because of the enhanced venodilatation. And this is in no way to promote it as an aphrodisiac, but we know that majority of our men shy away from antihypertensives because of erectile dysfunction. So if they have a molecule that will give them their intact sexual activity and also controlling their BP, I think it's a right in the step direction to help them be compliant on their medication. Finally, for those who are uncontrolled on dual therapy, we've put together perindoprol, indapamide, the thiazolide diuretic, and amlodipine as triplex-am, the triple therapy for more power. And with just one tablet of triplex-am, can get as high as 54 millimeter drop in mercury of systolic blood pressure in just 3 months. In addition to that, it's been shown through the advanced ECB that we have an unparalleled cardiovascular protection, a total mortality reduction of 28%. And so these are the various dosages available for triplex. We have 5 1.255, 5 1.25, 10, 10 2.55, 10 2.55. You realize that the indapamide in here is 1.25. Natrolex as a standalone is 1.5 sustained release. But when it comes in combination, it comes as 1.25. And always the lower doses matches with the lower doses of the perindopro, so that it balances the hyperkalemic and hypokalemic effects of each other. Whereas the higher doses of the ACE inhibitors also balances with the higher doses of indapamide. So this is the end of my presentation. Thank you very much. And I will open the floor for any questions. Okay, so we have one from Dr. Joseph Asari. Between ACE inhibitor and ARBs, which one would you recommend in renal disease patients? So I
Okay.
think this one will go to Dr. Jikun.
I think this is to me. And as the evidence was shown, when it comes to renal patients, reducing renal outcomes, both ACE inhibitors and ARBs reduce renal outcomes. But in addition, there is cardiovascular disease reduction in terms of cardiovascular disease mortality and all-cause mortality in ACE inhibitors. So if they are tolerant of ACE inhibitors, that will be my first choice. If they are intolerant of ACE inhibitors, then of course you go for ARBs. Thank you.
Thank you so much. So this from Dr. Atibo Fianko. Do you have any studies indicating reduction of angioedema in patients taking perindopro as compared to other ACEI? So I think this one will come to me directly. So we don't have a head-to-head study currently. We just have meta-analysis of the various the side effect profile of the RAAS blockers. And conversely, I think most of the angioedema issues has to do with the ACE inhibitors. So you realize that I have it, I have that slide, but I think I'll follow up with you and share with you. So in terms of we're head to head, we don't have, but we have a meta-analysis that shows that the incidence of perindopo is greatly reduced with the perindopo as compared to the other ACE inhibitors. And so I'll take your details and then send you that article via your personal email. Dr. Patricia Meredith, does perindopo have the same incidence of cough as compared to other ACE inhibitors? So I think this will also come to me. So perindopro, the incidence of cough with perindopro is greatly reduced as compared to the other ACE inhibitors, and it's because of its pharmacologic properties. We know that the incidence of cough has been associated with buildup of bradykinin in the lungs by the ACE inhibitors because they are not able to break it down. And so when you have the more hydrophilic ACE inhibitors like lisinopril, that is more water soluble, we know that the lung area is more water soluble. And so it concentrates in the lungs to cause the bradykinin buildup, which produces the cough. But because perindopro is lipophilic, its action is more in the kidneys. So yes, your patients may cough on perindopro, but the severity and the frequency as compared to other like hydrophilic ACE inhibitors is greatly reduced. So if your patient coughs on perindopro, it means they don't tolerate ACE inhibitors at all. So that's that. I hope I'm clear on that. Okay, so are there any indications in which ACE inhibitors and ARBs can be taken together? I think this one will be to Dr. Jikun.
The simple answer is no. There are occasionally, but that is done by a super specialist. So all the guidelines recommendations are saying that we should not combine ACE inhibitors and ARBs. Indeed, if you look at the study that tried to combine them, there was no additional cardiovascular benefit. What rather happened was there was increased risk of hyperkalemia, increased risk of other things. So it is not recommended that you combine ACE inhibitors and ARBs at this stage of knowledge in these diseases. Thank you.
Okay. I think there any other questions? I think we are getting exhausted with the questions. Okay. So I think the questions are done. I can't see any more questions. So at this point, if there are no questions, okay, there's one. For patients who cannot afford single pill triple therapy, can such patients be put on multiple pills?
I'm sure that is also to me again.
Yes, please.
As I said, the recommendation is for single pill, but if they cannot afford the single pill, put them on the multiple pills. But know that the higher the number of pills your patient has to take, the more likely they are to default in their compliance. Pill burden or pill load is very important when it comes to patient compliance. So this has been one of my advocacy areas. I agree with you. Some of the single pill combinations are very expensive. If you look at the WHO essential medicines list for 2020 or 2021, they have added single pill combination antihypertensives as part of the essential medicines list. What that means is that all countries must try and make these medicines available and affordable to our patients. Thank you. I
Thank
hope
you.
I've answered your question with so many ways.
Most definitely. Okay. Is any more questions? Amazing presentation. I learned a lot. Anita Global, thank you so much. Any more questions? Any more questions? Any more questions? Okay, so I think we are done with the questions now. So Dr. Jekun will just give us a 5 minutes or let's wrap up, and then we can close the curtains for the day.
All right, so this one will be off slide. I mean, the main point I think this afternoon has been very important. We've discussed very important issues. Hypertension is a very common condition that we have to deal with. Indeed, if we were able to control hypertension well, we will be able to control a lot of cardiovascular disease mortalities that we are faced with. Hypertension does not come alone. Hypertension usually coexists with other comorbidities. Hypertension with diabetes, hypertension with dyslipidemia, hypertension with coronary artery disease, kidney disease, and heart failure. You do not manage all your hypertension the same. So you need to consider the patient. What other comorbidities does the patient have? And this afternoon we have looked at one. If it is non-complicated hypertension, start with your initial dual antihypertensive therapy. For most patients, progress. The target is to be able to get to your blood pressure targets within 3 months of initiation of your antihypertensive therapy. If the person has other comorbid conditions, then you cannot equate all the antihypertensive medications. And we have looked at a lot of evidence to show that a lot of studies have been done on ACE inhibitors, and they seem to be much more better in terms of cardiovascular disease outcomes. Their blood pressure control is equivalent to that of ARB, but the added benefit in hypertensive with comorbidities in terms of cardiovascular disease outcomes, in terms of all-cause mortality, ACE inhibitors definitely have an edge over the ARBs. And that is the reason why, if you take a look at all the guidelines we looked at, they say that ACE inhibitors. If patients cannot tolerate ACE inhibitors, then consider ARB. So I think that should be the message for this afternoon. ACE inhibitors, if they cannot tolerate, consider the use of ARBs, and always manage your patient, not the disease. Thank you.
Thank you so much, Dr. Jekum. I would also like to say that as Severe, we are partners with you in managing your patients. We also want to give the best for your patient. So if you are looking for an ACE inhibitor, the best one, look no further than our perindoprol-based combinations, branded as Corvessel. And then if you need one with amlodipine, we have Coveram. If you need a perindoprol with indapamide, we have Corvessel Plus for your hypertensive diabetics. And then we have triple exam for all round cases who are uncontrolled on dual therapy, and it is readily available everywhere in the pharmacies and the various hospitals. Thank you so much for your time this afternoon, evening, and we are really grateful for the opportunity. We hope that this was a very interactive section, and we look forward to more engagements with you throughout the year. Thank you and have a very good evening. Thank
Thank
you so
you.
much, Dr. Jokun. Thank you so much, Dr. Kutu.
Thank you.
So we are
Dr.
really
Kutu, bye-bye.
Yes.
Dr. Kutu's internet is messing up. Okay, he's back
Yes.
now. Okay. Thank you so much, Dr. Kutu. Thank you so much, Dr. Jokun. We are really
Thank
grateful
you. Thank
for
you,
the
Cecilia.
solid information you've given us this evening. Thank
All
you.
right.
Have a
All
good
right.
evening.
You
Okay.
too. Bye-bye.
Bye.